Okay, welcome to part 2 of the forearm, elbow, and distal humerus anatomy. Let's begin part 2 by looking at this lateral elbow. So first, in part 1, we ended with olecranon fossa, and I want to point that out here now that we have a nice diagram that shows that. So notice this is my distal humerus, and the region of the olecranon fossa is going to be back here. And when we look at our bones in lab, you'll be able to see that is a deep fossa found on the posterior aspect of the distal humerus. And can you just picture for a second, this elbow is bent at 90 degrees. When you extend your arm fully, can you imagine that this olecranon process would slide up into that olecranon fossa? Yeah, so that's how that works. Okay. Let's just orientate ourselves with a little bit of the anatomy that we talked about in part 1. So here again, the elbow joint is bent at 90 degrees. You can see on the anterior aspect of the distal humerus, you have that radial and coronoid fossa. Again, remember those. And then here, you can see the epicondyle. Now, technically, what you're visualizing on an x-ray are the epicondyles, the medial and the lateral, superimposed over each other. And we'll spend time talking about that in lab, but can you kind of picture here how both epicondyles, the lateral and the medial, would be superimposed on an x-ray? Okay. You're also seeing this radiolucent groove here. That's your trochlear sulcus. Remember, that is the depression or the groove found on the trochlea. And then you're seeing the capitulum kind of on end here and the trochlea. Remember, the capitulum is a little bit smaller than the trochlea. So when you're looking at it from the side, it's going to look like the smaller of the two circles. Here again is that olecranon process that you can feel when you palpate your elbow in the back. Here is the trochlear notch on the ulna. Here you have the radial head, neck, and tuberosity. And then don't forget that coronoid process on the anterior part of the ulna. That articulates into the coronoid fossa when you bend your elbow. Okay, so positioning for an accurate lateral elbow with exactly 90 degrees of flexion is very important to help us evaluate any elbow joint pathology. So let's next look at an actual x-ray of a lateral elbow and talk about what we should visualize. A good way to evaluate for a true lateral with 90 degrees flexion is by the appearance of these 3 concentric arcs. So that is a term we'll talk about again in lab, but we look for the 3 concentric arcs to tell if we are correctly positioned or not for a lateral elbow. Okay, the first and smallest of the 3 arcs is the trochlear sulcus. Okay, and you can see that here. That is a radiolucent line. And remember, that is the groove or the depression on the trochlea, in between the 2 ridges of the trochlea. The second concentric arc is a combination of the capitulum and the trochlea, and you can see that here. So even though these are 2 ridges, they're so close together that they're considered one of the concentric arcs. The third concentric arc is the trochlear notch on the ulna. Okay, and you see that here. You will not see these 3 concentric arcs, and the elbow joint will not appear open if the elbow is not at a perfect 90-degree lateral, or if the shoulder and the elbow are not on the same plane. So we're going to talk about that in lab pretty extensively. You have to have the shoulder and the elbow on the same plane when you're imaging the elbow joint. So I know this is very difficult, but you can see here's trochlear sulcus, here's capitulum and trochlea, and then you have the trochlear notch. Okay. Also, remember we talked about the epicondyles should be superimposed. That is what you're seeing here. kind of this superimposed area of epicondyles. And I kind of think about, do you see this figure 8 here? Remember, the epicondyles sit above the condyle. So I like to think of this upper region as my superimposed epicondyles, the upper region of the figure 8. Okay, so more to come on that in lab, okay? Let's see if we can pick out some anatomy on an AP elbow. Remember, we learned this anatomy in part 1 of this lecture. Notice when we hang an elbow x-ray, the fingers are hung down. Again, that can vary depending on your radiologist preference. Okay, so A is our medial epicondyle. So right off the bat, you should be able to tell if this is a right or left elbow based on that huge medial epicondyle. So think about that for a second. B, this is the region of the trochlea. C is the coronoid tubercle. Remember, it's the medial aspect of the coronoid process. Coronoid process is here. It's not labeled on this x-ray. D is the radial head. E is the region of the capitulum. Remember, if it's directly above the radial head, it's got to be the capitulum. F is the lateral epicondyle. Remember, it's much smaller than the medial. And H is referring to the olecranon process. Remember, the olecranon process is the back of the ulna, and you can feel that when you feel your elbow joint. Now, I know what you're thinking, like, wait a minute, you said olecranon process is a posterior structure, and it is. It's so dense that you can see it on an x-ray. You can see it as though it's anterior. It's just so dense, it really sticks out on an x-ray. Notice this little kind of more darker gray area. That is olecranon fossa. That's the top of the olecranon fossa. Remember, this elbow is extended. So when our elbow is extended, the olecranon process slides into the olecranon fossa. Okay. All right, good job. Let's identify some anatomy on the lateral elbow. So G, again, is that region of the superimposed epicondyles. Okay, and I like to look for that figure 8, and I like to think G is kind of this upper part of the figure 8, the superimposed humeral epicondyles. I is pointing to that trochlear sulcus. Remember the groove or depression on the trochlea. J is referring to the trochlear notch on the ulna. K is referring to the capitulum and trochlea. Remember, capitulum is going to be the smaller of the two. L is referring to the coronoid process, and that's difficult to see, but if you kind of follow the ulna up right there, that's going to be that coronoid process. M is radial head, and N is radial neck. Okay, let's talk about joint classifications real quickly. The elbow joint is a synovial joint. It's freely movable, so it's going to be diarthroidal. Okay, so remember, synovial is a structural classification. Diarthroidal is a functional classification. The elbow joint is considered a ginglemus joint with flexion and extension movements between the humerus and the radius and the ulna. Actually, though, the elbow joint contains 3 different joints in one articular capsule. So in addition to the ginglemus joints found between the distal humerus and the radius, and the distal humerus and the ulna, so there's 2 joints right there. So one joint here, one joint here. You also have that proximal radioulnar joint here. Remember, the proximal radioulnar joints, again, is a trochoid or pivot joint. As we discussed earlier, The radio-ulnar joint allows for the radius to rotate around the ulna, and it actually crosses over the ulna when we pronate our hand. Although imaging the forearm with the hand pronated may seem natural and more comfortable, when the radius and ulna are crossed, as you see here, we could easily miss pathology or a fracture. So we always image the forearm with the hand supinated in a true AP position. And that way the radius and the ulna will always be parallel to each other rather than crossed. All right, let's conclude part 2 of our presentation by discussing fat pads of the elbow. We will discuss positioning of the forearm, elbow, and humerus in week 9. Okay, so there are 3 fat pads of the elbow, and they are only visualized in a lateral position. They're not seen in an AP position because of the superimposition of the bony structures. Remember, fat pads are very small radiolucent structures. So in an AP position, the bones just totally cover up those small radiolucent structures. Okay, the first fat pad that I want you to know is the anterior fat pad here. It is seen anterior to the distal humerus. Trauma or infection can cause this anterior fat pad to be elevated and more visible, or even distort its shape. It's normally a teardrop shape, as you see here. The posterior fat pad, D, is located deep within the olecranon fossa, and it's normally not seen on an uninjured elbow. So in other words, if the elbow has no injury to it seen radiographically, we call that a negative elbow exam. So on a negative elbow exam, you should not see the posterior fat pad because it lives deep within the olecranon fossa. And remember, when our elbow is bent 90 degrees, the olecranon process isn't in the olecranon fossa. That fat pad is in there instead. If we see the posterior fat pad and the elbow is positioned perfectly at 90 degrees of flexion, that tells the doctor that there's been a change in that joint, which has caused the fat pad's position to change, and that suggests some type of pathology. So let me say that again. If the elbow is perfectly positioned at 90 degrees, if the shoulder and the elbow joint are on the same plane, and if there is no injury, we should not see that fat pad. The posterior fat pad. If our positioning is perfect, if there is both joints are on the same plane, the shoulder and the elbow joint, and we see the fat pad, that tells us, whoa, something happened in that joint. There's some type of inflammation or fluid collection that's causing that fat pad to be displaced out of the olecranon fossa. So again, to ensure accurate diagnosis, the elbow has to be flexed perfectly at 90 degrees. Okay? If the elbow is extended at all, if the arm is straight at all, that's going to cause this olecranon process to slide into the olecranon fossa. And that's going to push that fat pad up out of the fossa. This could cause a false positive diagnosis by the physician. We want to avoid that, of course. So to summarize, on a normal or negative elbow x-ray, we should not see that posterior fat pad. Poor positioning can cause the posterior fat pad to become visible. Okay, so on a negative elbow, you should not see the posterior fat pad. Okay, the last fat pad we need to know is the supinator fat pad. You can see that here. That is a long, thin stripe just anterior to the proximal radius. It may indicate the diagnosis of a radial head or neck fracture that isn't super obvious. And remember, sometimes we can have injuries to the joint that don't include a fracture to the bone. I mean, you can sublux or partially dislocate a joint and there's no fracture to the bone. So again, these little fat pads tell our doctors like, hey, something happened to this joint, even though there isn't a fracture. In this case, of course, there is a pretty significant fracture here, but that isn't always the case. That's why optimal exposure techniques and perfect positioning are so important. All right, we're going to conclude part 2 here. As always, if you have any questions, please let me know, and we'll talk about all of this again in lab. Thank you.